Hi, thanks for watching episode number 74 of the Doctor Podcast Show. We appreciate you tuning in. We have a very informative and educational show today with a great guest. I'd appreciate if you could subscribe and follow to Doctor Podcasts and also like and repost this episode. We'd appreciate that because that'll get us additional great guests like we have today. Our guest today is Dr. Alan Wu. Dr. Wu is a professor of clinical medicine at the University of California at San Francisco, a major medical center in the USA. He's the chief of clinical chemistry and toxicology laboratories at the Zuckerberg San Francisco General Hospital, major hospital. And he's a chief of the clinical pharmacogenomics laboratory there as well. His research interests include clinical toxicology, cardiac biomarkers, and point of care testing. Dr. Wu has published over 500 publications in peer-reviewed journals, and he's written several paperback books consisting of short stories designed to promote the value of clinical laboratory education and information to the general public, which is very important. We'll talk about that. He's a leading expert internationally about hemolysis detection. We're going to spend a lot of time on that today because it's a very important topic. It's a critical issue in hospitals and various parts of hospitals. We'll talk about that. And especially, for example, in neonatal intensive care units in hospitals, or they're referred to as NICUs. It turns out that about 47% of blood tests in NICUs sometimes have an error because of this hemolysis problem. And we'll talk about that. And Dr. Wu will discuss some new, incredible, innovative technology that will avoid those errors or try to eliminate them completely. So, Dr. Wu, thanks very much for joining us today. You're a very busy guy running a lab in a hospital, so I appreciate your taking the time to come here today, Doctor Podcast Show, and educate us about this. Can you tell us what clinical chemistry and toxicology laboratories are in a major hospital, and what does that laboratory do?
Well, thank you, Robert, for inviting me to Doctor's Podcast. It's an honor and privilege to be on your program.
Thank you.
So, the clinical chemistry laboratory is a subset of laboratory medicine, which is charged to produce clinical laboratory tests to our patients, whether they be in our hospital or outpatients or clinic, that we do all of the testing and are somewhat behind the scenes in terms of providing objective information that doctors need to make medical decisions.
Right. Testing is critically important because it helps the doctor decide what's going on and how best to treat the patient. I think patients and the public don't have an understanding of that because it's become so automated and perfected that you go into a lab or a hospital or doctor's office, you get your blood drawn, and then within 24 hours you get the results on your phone, and you just assume it happens that way. But there's a very vast, complex um, infrastructure that's required to get that done. We're going to talk about that today. Tell us also what the clinical pharmacogenomics, sorry, that's a tongue twister, what that laboratory is.
Well, that's a subspecialty of toxicology and laboratory medicine, and it involves conducting tests to determine if a particular drug that has been prescribed is going to be either effective for the disease that you might have, or does it have a possibility of causing adverse events or harm. And obviously, we don't want to create more of a problem by giving the wrong drug at the wrong time. And pharmacogenomic testing allows us to do a better job at predicting outcomes.
So it's kind of a customized medicine. By knowing the genomics of the patient, you can match the drugs more accurately and perhaps prevent side effects and adverse effects to medications.
That's absolutely correct, Robert. And it's what we call now in the modern vernacular personalized medicine.
Right. So we can customize the treatments for the patient and avoid possible problems, side effects from the medications, make it easier to treat the patient. Tell us about the laboratory at San Francisco General Hospital that you're the head of. How complex an operation is that? How many people work there, and how do you run that?
Well, it is a very complex center, as you have alluded to. We have hundreds of people, and they're divided into various subsections. So I'm not the head of the lab, but I'm the head of the chemistry department. We also have pathologists and laboratory scientists in hematology, immunology, the blood bank, microbiology, toxicology, which is also one of my specialties, and also the before mentioned pharmacogenomics.
Very complex, a lot of people working there, making sure patients get good health care. Now, one of the things that you're an expert in is hemolysis. Can you explain what hemolysis is and what specifically hemolysis in a blood test means?
Well, you, as you know, as a physician, that there are patients who have hemolysis due to bleeding, that their red cells have become broken and they release the contents of their cells into the blood itself. That is a significant medical situation, which we call in vivo hemolysis. What you are referring to also is something that we call in vitro hemolysis. It's not that the patient has bleeding, but that when blood is collected, the specimen becomes hemolytic. The red cells break down, and it is a form of what we call pre analytical error. It's a problem that occurs with the specimen before it actually gets put into our analyzers, but it doesn't reflect what's going on in the patient's body.
Right. So now blood can basically be broken down into two components. You've got the red blood cells, white blood cells, and then you've got the serum, which is the fluid that these cells float in. When you do testing of a blood sample, you're basically testing things in the serum, and you're also testing things in the blood. Now, if the blood cells break down, then the contents of the blood cells get into the serum, and that causes errors. Is that what's happening?
That is precisely what happens. The red cells break open the contents of the cells, principally hemoglobin, but also other things like electrolytes get leaked into the water layer of a sample, as you called it, serum, or it could be plasma. And usually the serum or plasma imparts a pale yellow color, but because hemoglobin has a bright red color, which gives the red cell its name, it turns the plasma or serum red, and that's where the problems become.
So then the machines that you have, very complex, high technology machines, read the sample incorrectly and come up with incorrect results, which makes taking care of the patient much more difficult, right?
Yes. So the concept of hemolysis has been known for many decades. And in the central laboratory where we have these large analyzers, we have workarounds. We can look for the presence of hemolysis by detecting the red color of the sample. And when that happens, we can send a note to the doctor saying that this sample has a hemolytic component. The results may be inaccurate, and that a consideration should be taken for recollecting it.
Right. I remember I'm an ophthalmologist, so I don't do the actual blood tests at this point, but I remember when I was a medical intern years back, I used to actually collect the blood from the patient and then send it to the laboratory. And occasionally the laboratory would call me and say, Dr. Seiker, the sample's no good. We can't test it because there was hemolysis. And so I'd have to take another blood sample. So that's an example of that. So what parts of the hospital are affected by this? Because you've got intensive care units, like I mentioned, the NICU, you've got emergency rooms, and you've got patients who are in the hospital as inpatients, and then you have outpatients as well who may come to the hospital have their blood tested. Uh, how is hemolysis affecting these different types of patients?
So the rate of hemolysis varies by where the specimen is taken, how sick the patient is, and how good the person that is collecting the blood is in terms of retrieving it. So if you are healthy and you have nice thick veins and you have a phlebotomist who's highly trained, hemolysis is not so much of a problem. On an outpatient basis, the incidence is pretty low. But when you have emergency department or intensive care unit patients, and we'll talk a little bit later about the NICU, that's a special case. You
Right.
have people whose veins might not be so strong. They might have cancer or they might have drug abuse. It's more difficult to collect blood from them. Sometimes the technique is not as good as on an outpatient basis because you're in a chaotic ward with patients coming in and out and screaming, and it's never a pleasant experience. And that's what causes mistakes.
I see. So it depends on what type of patient it is. Now, ideally, you would want to identify that a specimen has hemolysis in real time so that you don't analyze the sample, get incorrect results, and then have to repeat it. Um, there's new technology, I understand, that you're an expert in, which will pick up hemolysis in real time. Is that correct?
Well, if I could, Robert, back up a step, I mentioned that the central laboratory, so if a specimen is sent to my lab, which is not in the ED or in the ICU, we have instruments that look for hemolysis on a routine basis in real time. The problem, however, is that the newer technologies today allow us to do testing on the ICU and emergency department wards themselves. And that allows us to give results back quicker than having to send the sample to the laboratory. And in these areas, turnaround time for lab results is more important. Now, another time savings event is that we can take this whole blood sample and test it for certain critical analytes without separating the cells from the serum or plasma like we do in the central laboratory. That step is another 10 or 15 minutes that adds to the turnaround time. So not only do you have to deliver it, but you have to spin it, and then you have to separate it, and then you bring it to the analyzer. These blood gas and electrolyte analyzers now can do the testing at bedside without spinning the blood.
Wow, that's pretty amazing. That's huge time savings, especially in the emergency room where patients may come in critical condition. You don't really know what's going on, and the result of the blood test is critical. The quicker you get it, the better.
Correct. And that these blood gas analyzers have been around for many years, 20, 30 years, and that's not the innovation. The problem is that if you have a hemolytic sample and you don't centrifuge it, you don't know that it's hemolytic because the red blood cells obscure the red pigment from the hemoglobin. And there's no way to know that that sample is, in fact, damaged.
Interesting. I'm going to play a short video now about hemolysis, and then we'll get back to the questions.
Story shows the importance of getting an accurate potassium test result on blood. Mindy suffered from drug abuse and lost her job as a housekeeper. When she ran out of money, she was evicted from her apartment and became homeless. One day, her right leg began to swell up. She was able to tolerate the pain for many days, but when it became unbearable, she went to the ER. In addition to wound cultures, her doctor checks her potassium level in her blood. Getting an accurate potassium level is essential for patients like Mindy. The normal value is between 3.5 and 5. If the potassium is low, the mortality risk can double. If it's high, the death risk can go up 8-fold. Symptoms of low potassium include muscle weakness, spasms, and fatigue. Patients with high values can have shortness of breath and an irregular heart rate. Today, testing for potassium in blood is conducted in 2 ways. The most accurate test is to have blood sent to a clinical lab. It takes 45 minutes as it must first be delivered to the lab and then spun to produce serum. In an emergency, results can be obtained within 5 minutes using bedside instruments that measure potassium directly from whole blood without centrifugation. Red cells can be damaged during collection and transport. This releases hemoglobin, a protein that is red in color. Potassium is also released and produces false high values for this mineral. When serum is tested from a clinical lab, hemolysis can be detected by the presence of the red color. When present, a notification is attached to a report alerting doctors that a false increase has occurred in tests like potassium. In this situation, the medical team usually repeats the test by collecting a new blood sample. Unfortunately, when unspun blood is tested, the dark red color of blood obscures any hemolysis that might be present and no alert is provided. Mindy's potassium was normal. The astute doctor suspected that her sample was hemolyzed and that her actual potassium was low. Homeless patients often have low results due to poor diet and through gastrointestinal losses. Low potassium weakens the immune system and makes infection worse. The doctor asked for a recollection of blood, but by then, Mindy had left to tend to her dog Abe, whom she had left with an unreliable friend. A few days later, Mindy returned complaining of muscle cramps and weakness. Her infection had become necrotic. The inability of the doctor to get an accurate potassium result when she was first initially seen led to an ambiguity of Mindy's level, which resulted in a delay of her diagnosis and treatment. Mindy recovered from her infection with treatment. Later, she received rehab for her drug addiction, found employment, and was soon off the street. Abe was with her every step of the way. New whole blood potassium analyzers will be released soon, which enable rapid hemolysis detection without having to send samples to the central lab. Stay tuned for more lab tales.
Now, can you talk about how an emergency department or emergency room is affected by this hemolysis problem, and what can be done to fix that problem?
So there are some analytes that we test on a regular basis that are more affected by hemolysis than others. The key is whether or not that particular analyte is found in higher concentrations within the red cells themselves as opposed to the serum or plasma. Now, sodium, which is an incredibly important analyte, is not affected by hemolysis because most of the sodium is outside the cell already.
I see.
Potassium, on the other hand, an equally important analyte, some would say even more important, is predominantly found in the red cells. And so when you hemolyze and break open that red cell, it comes pouring out. And what's present before hemolysis gets increased dramatically with hemolysis. And that's just one of the analytes. There are several others that are affected in a similar manner.
Right. So the analytes are the different chemicals or electrolytes or other substances in the blood that you're testing for.
That's correct.
Right. And if the red blood cells are broken and leak all this potassium into the serum, then you're getting abnormal potassium levels, but that may be incorrect or inaccurate. The potassium may be actually normal. Or if somebody has very low potassium, which is dangerous, but their red blood cells leaked out this potassium, you may be tricked into thinking that they have normal potassium levels. Is that right?
Yes, you were very well trained in your internship.
Yeah, yeah, I
So,
still remember after all these years.
and that just highlights the importance of these concepts. So, the thing about potassium is that the normal range is extremely tight, 3.5 to 5.0. And so it doesn't take much of a leakage to produce an erroneous result. We have other tests where there's wiggle room. If you have a cholesterol of 190, and then the next time you run it, it comes out 199, nobody cares. You're still
Right,
good. And that's a 9-point difference. If you had a 9-point difference in potassium, in which you can see that in a hemolytic specimen, that's night and day.
right. Potassium is critically important for the heart conduction system. It keeps the heart ticking in a normal rate. So any very high potassium or low potassium can cause heart problems, heart failure, or even stoppage of the heart. So that's critically important, right?
Yeah, uh, that's the reason that our bodies keeps our potassiums in such a narrow range. We have um, countermeasures that can reduce a high potassium and vice versa under normal conditions. But then, if you have a disease or a medical problem, let's say renal disease, your potassium is going to go up because you're not able to excrete it, you're not able to regulate it. If, however, the increased potassium is due to hemolysis, you're going to get the wrong answer. You're going to say, there's something wrong with my patient's kidney, when in fact, there's nothing wrong.
Right. So the potassium level, accurate potassium level, is really critical. What about, we mentioned the NICU, or the neonatal intensive care unit, as another very important place where the blood test results are critical. Can you tell us about that?
Yes. So, um, NICU, which, as you indicated, stands for Neonatal Intensive Care Unit. Many of these infants are premature. They were born early. They are very small in stature. You like to have a child that comes out that is 8, 9, 10 pounds, healthy.
Right.
But in the NICU, we have children that are 1 pound or 2 pounds, 1/10 of what we'd like. And if you think about how much blood is present in a infant and divide that by tenfold, now you can see that there's just so little blood in an infant that it becomes very precious, number one. You can't afford to take very much in order to do a diagnostic test. And when you do take that amount, you hope that you get the answer right, because you don't ever get a second chance. No one's going to continue to stick that child until they get a result. The
Right.
problem is that these infants, not just the normal infants, but in particular those in the NICU, they have super tiny veins. You can't even see them. You can't do routine phlebotomy. You have to stick their heel and then massage the heel to cause bleeding and drip it into a tube. And
You
that
can't
too,
get the needle into the vein, as with an adult, you can usually get a needle into the vein and get blood. In a tiny premature baby, you can't do that.
exactly. And when you do, you don't get very much, and the blood that you get from a heel stick is not as robust and accurate as in a venipuncture.
Right. So, how does your technology help with that type of problem? Because we have limited supply blood, and we have to be absolutely certain that we get the correct test results so we know how to treat that baby.
So, first of all, it's about training, is to ensure that the people who are collecting blood are absolutely competent in doing it. You don't want somebody who is inexperienced treating your child who might have other medical problems. And so you definitely want to have people that are the best of the best, as we sometimes say. And even in those conditions, the rate of hemolysis is going to be high, as you indicated at the outset, could be 47%, maybe not just hemolysis, but other problems as well. And so while we do the best we can to reduce the hemolysis rate, I don't think that we can ever eliminate it because it's the difficulties of collecting blood on some individual that fits in the palm of your hand.
Right.
So visualize that. Um, but if we are going to do laboratory testing, let us at least, at a minimum, determine if there is an error in the sample or not. And we can do that now with our modern technology. We can determine in a whole blood a heel stick sample if there is hemolysis. And if there is, that is a different answer than if it's not hemolytic. And the neonatologist can take that into consideration when they're making their medical decisions.
Critically important medical decisions. You sometimes don't get a second chance in these tiny babies. Now, there's also a huge economic impact if you're getting a lot of hemolysis and wrong laboratory tests, and that you have to repeat tests and do them over again, and that's very expensive. Is that right?
Yes. So our policy is that when you have a sample that's been determined to be hemolytic from our mainframe chemistry analyzer, we first determine the degree of hemolysis, and then we determine what tests have been ordered to ascertain whether there is a major effect or a minor effect. If it's a minor hemolysis, then we can report the result with a note saying that this sample has minor hemolysis and some of the tests will be affected, not all. The potassium, yes. Some liver enzymes, yes. If the sample is heavily hemolytic, then we take the stance that we should not report it at all because we don't have any idea of what the true value for these analytes will be. And we don't want to contribute to an incorrect interpretation of the result and incorrect medical actions taken. And so in an adult, the best approach is to recollect. Now, that takes time, that takes effort. You're doubling the effort because you have to recollect. And of course, there's no guarantee that the second sample won't be hemolytic as well as the first.
Right.
And then there is the delay in getting the result of a critically important analyte, like electrolytes. Nobody wants to wait around to find out, oh my gosh, this is abnormal. We should have done something earlier.
Right. Especially in critically ill patients or babies in the NICU. So tell us about this breakthrough hemolysis detection system called the GEM Premier 7000. Tell us what that is and how it works.
So, for the very first time, a blood gas electrolyte whole blood analyzer will allow us to determine the presence or absence of hemolysis, and if present, the degree of hemolysis equal to what we can see in the central laboratory without sending the sample to the lab, without centrifuging the sample to separate the red cells from the plasma or serum.
Wow. So does it give you an accurate reading right there? For example, let's say it reads a potassium of 6.5, which is abnormal, but it also tells you, look, there was hemolysis here. So the real potassium is 4.8, not 6.5? Or how does that work?
No, we can't do that. We are not able to calculate what the potassium would have been had we known the hemoglobin content. And the reason is that the amount of potassium in a red cell varies. It might be because of the age of the red cell. It might be because of the hemoglobin that might be present, the hemoglobinopathy. There are many factors that don't allow us to calculate potassium with the knowledge of the hemoglobin content.
I see.
What it can do, however, is alert the physician that the sample is artificially increased by some amount. And we can't give you the exact hemoglobin level, but we can do a qualitative assessment, a semi quantitative assessment. It's either normal, +1, +2, +3, or +4.
I see. And that's available in real time to the physician, as opposed to having to send a sample to the lab, waiting for it to be analyzed, waiting for the lab to get back to you.
That is the beauty of the GEM 7000, that in the time it takes you to get the electrolyte result, you're also getting the hemoglobin content or the hemolysis assessment, and you're not waiting for the sample to tell you that from the central laboratory.
That seems like an awesome improvement, because if you have a really sick patient in the intensive care unit or the NICU, or somebody who just got wheeled into the emergency room, you sometimes don't have time to send the specimen to the lab and hope that it was a good specimen. You find out right away.
Yes, it is a correction of a potential medical error.
Right. Now, is the Gem Premier 7000 available right in the emergency room or the NICU or the ICU?
Yes, the instrument was launched this summer, and it can be used in any of those scenarios in the same way.
Uh, that's a huge improvement. What's the footprint like of this machine? How large is
It is a bench level instrument, um, about the size of a 17-inch computer monitor, for example, with a base. It's not meant to be on a cart or wheeled from patient to patient. There is a lot of sophisticated electronics, software, optics that make all of the magic happen, and it can't be miniaturized.
Right. So basically, for example, in NICU, you have a devoted space to the Gem Premier 7000 machine, and when the doctors or nurses draw the specimen from the tiny baby's foot, they can bring it directly to the machine and get results right there.
That's correct.
That's a huge improvement over the way it's been in many decades. That'll save a lot of time, save a lot of lives. Um, what about the technology? Can you explain in terms that we'll understand how this technology has evolved and how you're able to do this?
Well, there's some pretty bright people that have discovered this.
Right.
It's something called acoustic wave plate fluidics, which is some a wave that is applied to the sample as it's flowing by the sensor, that allows you to separate fluid from particles. The particles in this case would be the cellular elements, the red cell. And then in that little window that you've created, you can flash a light like we do in the central lab, and then determine how much hemoglobin is there.
Wow. But it's done in real time right away, which is a major difference.
Yes.
So are hospitals online to buy this equipment? Because it seems like it would improve healthcare dramatically, especially in very sick patients. Um, how many hospitals have this now?
Well, it just was launched, and so it's still very much in the upswing. There's a lot of things that have to happen for new technology to be put into service. You have to uh, cost justify. Sometimes you have to find space. There may be training. There may be service. And so it doesn't happen overnight for any new technology. Um, but at least in this example, the value of hemolysis detection is evident. It's not something that you really have to convince. Anybody who knows the problems of hemolysis will want to have this instrument.
Right. I hope you're getting the word out to all the other clinical laboratory directors around the country, because this is a huge improvement, and to the hospitals as well. Tell us about another system. It's called the IQM3 system that also automates quality checks and improves operational efficiencies.
Yes, IQM stands for Intelligent Quality Management, and it's software that interrogates the signals that are generated by the instrument in producing the results that it's intended to. Now, IQM is not unique to the GEM 7000. This was a system that was developed in the earlier versions of this instrument, although with each generation it's refined and improved. So I mentioned that this is a bench level instrument, very sophisticated, and part of the reason is these quality checks that this instrument can do. Now, there are other strategies for doing point of care, whole blood, electrolyte, and blood gas analysis. These are the so called handheld devices. The advantage is that instead of bringing the sample to where the instrument is, you take the device in your hand and you go from patient to patient, bed to bed. And there is no delay. You get your sample and you put it into the instrument immediately. That's the advantage. And if you have a large unit where the instrument is some distance away, that could be very helpful. The downside, in my opinion, of handheld devices is that the quality is less, that we don't have these real time online checks because they don't have the ability to put in the extra hardware necessary to make this. And I would also venture to predict that hemolysis detection will be extremely difficult to do on these handheld devices, at least as of right now.
Right. As you shrink the hardware, it becomes more complicated to get the accurate results because there's a limit to the circuitry and other technology that you can incorporate into a smaller instrument.
Yeah, it's a compromise of space versus quality. You know, sometimes you can't justify the space. Imagine that if you were in outer space, or let's say you were on a cruise ship and you needed to have medical services, it's unlikely that you're going to be able to devote much space to a instrument that you will only occasionally use. And so these handheld devices become ideal in those scenarios.
Right. As a screening tool in certain situations.
Yeah,
Now,
or maybe out in the field, you know, in combat or you know, military. There are definite applications for both.
right. Now, does the Gem Premier 7000 require a technician that's specially trained on how to use this, or can you teach this to the neonatologists and the ICU doctors and the nurses?
Yeah, so when I talked about the laboratory, I mentioned that we had these different sections, and each of these sections are, in fact, manned by highly qualified clinical laboratory scientists who have schooling and licensures and training and sophistication. The other part of testing is what we call point of care testing, where we bring the devices into the units and they're not manned by our highly qualified laboratory technologists. And so they are what we call moderately complex or even waived technology, meaning that the knowledge needed to obtain good results is a lot less, that there are checks and balances, and the procedures are very simplified so that a professional, a nurse or a doctor or a resident, can run the tests, but they're not necessarily laboratory professionals.
So that's a huge advantage as well, because you can have this machine used by people who don't have the vast knowledge and training and experience and background that's available in the lab.
Yes, so you really need to make it foolproof and simple and easy to operate. And these instruments are extremely easy to operate. You mentioned this push a button, a needle comes out, you put the sample in there, wait a few seconds, the needle retracts, off you go.
Wow, that's incredible. So it seems like every Quest and LabCorp office should have a Gem Premier 7000 there.
Well, it depends on the scope of testing that they're asked to do. Sometimes in wellness, we don't need some of these analytes on a regular basis. It's not just the blood gases and the electrolytes, but it's everything else that's needed. So you need to test your cholesterol or your glucose or your renal function or your liver function. And to have an instrument that only does part of that menu might not be sufficient.
I see. Which specific tests or analytes can the Gem Premier 7000 do?
So it is primarily a arterial or venous blood gas. So you're looking at pH, PCO2, PO2, bicarbonate. The electrolyte profile, sodium, potassium, chloride, CO2, some renal function like creatinine or BUN. So the menu is limited. Glucose is obviously a very important analyte as well.
Those tests you just mentioned are the most critical tests that a person's life is dependent on. The electrolytes, the kidney function, the glucose, and how much oxygen you have running in your blood. So those are the most important tests. If your cholesterol's up 20% or so, it's not an emergency to get that controlled, right?
That is the criteria. That if we're going to make immediate management decisions, then those are the tests that you want to have on hand. If somebody has cirrhosis or cancer, we're not going to be so concerned of getting that result in 15 minutes because these are chronic conditions. On the other hand, if you have chest pain and you're suffering from a heart attack, the next generation point of care testing doesn't exist quite yet, will allow us to test for cardiac markers in the point of care. Right now, most of that's done in the central laboratory.
Wow. Sounds like a lifesaver to me. It's an incredible technology. I wish I had this when I was an intern instead of waiting 8 hours or so to get the results of a blood test on a sick patient where I didn't know exactly what was going on. So I'm sure all the intensivists and intensive care doctors will really appreciate this. Tell us what you see in the horizon coming in the next few years, a new technology and equipment to make this even smoother, faster, more efficient, more accurate.
Well, I alluded to some of that we're going to need to have new tests that can be done quickly. One area that I see tremendous growth is in neurologic diseases. So we're talking Parkinson's and Alzheimer's and traumatic brain injury, stroke, seizures. We've kind of fell behind, and rightfully so. These neurologic diseases affect the central nervous system, and abnormalities are easily seen when you do a spinal tap and you collect spinal fluid. But if you have to test blood, which is obviously more safe and convenient, you need really high sensitivity platforms because the amount of substances that cross the blood brain barrier is a small subset. It's like salmon swimming upstream. You have a concentration gradient going in the opposite direction. So we're going to see new tests that will start helping us diagnose and monitor and predict neurologic diseases in the same way that we can do now for heart, lung, kidney, and liver.
Right. I just saw recently, a couple of months ago, that they have blood tests now to diagnose Alzheimer's by measuring amyloid levels, tau levels in the blood.
Yeah, and the key is we now have emerging pharmaceuticals that can arrest Alzheimer's development and therefore improve our later stage quality of life. 10 years ago, it was not so evident that we would get there. And so you couldn't do anything about it. There was no reason to test.
Right. So we have a couple of drugs, I think 2 or 3 drugs now that are approved for treating Alzheimer's, for example. The key is to diagnose it early with easier testing so that you can treat these patients early on before their disease progresses to a severe stage.
You're absolutely correct. And so the strategy for testing is dependent on the need for rapid results. In the Alzheimer's disease, that is not a stat test. We're not going to need to do that using a point of care device. It's not a diagnosis made in the emergency department. We
Right.
have a luxury of time. But let's go the opposite direction. A kid falls off his bicycle, hits his head, and you need to know, is there TBI or not? Because if there is, we're going to expect a lot of longer term issues that we have to deal with. And so that is a situation that I predict that we're going to be doing more of using point of care devices because the information has to be delivered immediately.
Right. So you may be able to do a blood test to determine if a child has a concussion and treat as quickly as possible.
And there's just so many scenarios of TBI that we've not done much with. The military, for example, professional athletes, the elderly who fall and they're unwitnessed, and we don't know if they hit their head or not.
Right.
Child abuse is not something that people like to talk about,
Right.
but we have to. And that is also TBI. So lots of areas yet to be explored.
Right. Well, this has been very informative and educational for me, and I'm sure to the audience out there. The Gem Premier 7000 sounds like incredible technology, and I'm glad you're spreading the word about it, and it's going to help lots of people. So,
Well, I just like to say that you have become part of the solution with Doctor's Podcast because, as you indicated, the word needs to get out. How do you disseminate new technology? And it's through programs like this.
right. Well, thanks very much. I appreciate that.
All right.
And thanks for taking the time from your busy schedule to appear in the program today. I appreciate it.
It was a pleasure.
Thank you.